I'm Linda Fleisher. I am a research scientist here at CHOP and also an associate research professor at Penn and Fox Chase, and really spent a lot of my career developing digital health interventions and beginning to look at how do we think about integrating them into practice. So I think what we want to do in our panel is talk a little bit about going from research to implementation and how do we think about that. So I'd like to introduce, or at least mention, our panelists today, and as they come up, they can add more to that, as I've already introduced myself. You've gotten to meet Bimal Desai, who is our Chief Informatics Officer and actually oversees our new Office of Digital Health in addition to informatics. And Lisa Schwartz, who is a research associate professor here within Perelman and also a clinical psychologist in oncology at CHOP, and a digital health researcher who I think really will be able to dig a little deeper in terms of some of the research she is doing that's more pediatric focused. I'm going to talk a little bit more about sort of overall the research that we're doing at CHOP, and Bimal's really going to be focusing on sort of how we're developing and integrating digital health into operations. So kind of to give you that breadth. I'm not going to spend too much time talking about sort of the future. I think, we've had such a great setup to this already this morning, but it really is around, it's requiring innovation. And innovation is broader than digital health, but I think digital health is such an important component of the innovation that's really happening. And there are lots of definitions that we might look at in terms of mobile or digital health. This is sort of some of the aspects, I think, and I loved what Bimal said. I would love to think about interventions in the future not being distinguished between digital and non-digital. It's really this integration. But I think sort of some important pieces of this really have to do with, we're talking about these, mobile or wireless devices, the technology. But we're also thinking about deploying that technology in a variety of ways, from something that's maybe simple, maybe not that simple to implement, but say scheduling, to interventions that are really quite complex in terms of self-management, that may have multiple components and tracking and feedback. So again, I think we also have to think about these things as on a broad range of what we're trying to impact in terms of behavior. And I really like this last piece in terms of really thinking about it. I think it's already been said, it's not just the technology, but what are the active components that we're building into that technology that we really think is going to change behavior or change processes. So it's really this combination that's important, and I think as we're thinking about digital health. Again, the data is there. They are ubiquitous. Technology is ubiquitous. It's part of our life. It's part of our lifestyle. I think for us, many of the age groups that we're working with, both in terms of the children and their families, are on that younger end and much, much more likely to be using technology. They're using social media as well. This is from the Pew Internet. Fully 95% of teens have access to a smartphone, and 45% say they're online constantly. And I think if you're around anyone who's in that age, you would probably agree. We've done some surveying and research here at CHOP as well. This is just from one survey that we did, sort of asking parents in primary care. 88% said they owned a smartphone. Much less, though, have said that they've actually used that for a device to look up information around their child's health. And even fewer have said they've downloaded a specific app for their child health. So I think it gets at this point that's being raised already. The technology's there, but we really need to understand more how people are using these technologies for managing their health, and how do we improve what we're providing so that they are used more frequently. So for us, as sort of setting the stage for our panel here, really thinking about this from both the research perspective and then the clinical operations. So for us, our research institute, we have a cadre of digital health investigators I'm going to tell you a little bit about. We have our information system supporting a lot of that work through our research. Within the health system, we have, as Bimal has already described, I'm going to go into more depth, our Office of Digital Health and kinds of how we're thinking about digital health and operations. And then we've got a lot of processes to bring those two worlds together, because I think we're doing a lot of very innovative things in research, and we want to be thinking about how does that really connect back to our clinical operations, but also how do clinical operations really drive our research? So really, where is that intersection? And so one of the things we have done is kind of looked at our portfolio of digital health research. And that's sort of at a very high level. Right now, CHOP has over 64 funded digital health projects, which is, when we took a look at that, we were quite pleasantly surprised to see the depth of research that's going on here at CHOP. And again, using this whole range of technologies, from text messaging to video games to 3D printing. So again, this wide range of how to think about technology to really change behavior and have health impacts, but from a research perspective. And again, in terms of the kinds of studies and the kinds of issues that are being addressed through this research is also quite broad. Everything from online care plans, which Lisa's going to talk a little bit more from her own research, sexuality and risky behaviors, physical activity, asthma management, mental health, teen driving, all the aspects as we think about pediatric care, in some ways are being touched with our digital health research here at CHOP. One of the other pieces I think that is really, to me, very exciting about how CHOP is approaching a lot of this is through our various affinity groups. And Lisa Schwartz, myself, and Nadia Dashians, who's an adolescent pediatrician and also a digital health researcher, are leading this group of digital health researchers here at CHOP through this research affinity group. And part of the affinity group is really to foster collaborative efforts. So we have our diverse set of researchers. How can we work more closely together? Where are the things that we want to be learning more? For example, this year had a couple of sessions really having to do more with some of the more interesting and advanced technology and research designs around digital health. And also that bringing together and providing a forum for networking and educational opportunities. I think the other aspect of this research affinity group is really, again, being that liaison between research and what we're doing in research with operations. And so this has really been an exciting way to collaborate with the Office of Digital Health and some of the other hubs within the institution. And we have a blog, so you're welcome to go and look at our website. But what's really amazing and exciting is this research affinity group has over 240 members. One of the things we purposely did was make sure it wasn't just faculty, but it was the technologists, it was administrators. So again, I think one of the really exciting things to me about digital health is it is truly multidisciplinary. You cannot be a digital health researcher by yourself. It really takes that community, and we've really developed that. So there are, again, a number of elements and groups that are coming together to really create these connections, to really think about, again, and as we have research-tested digital health interventions, how do we move them into practice? And again, this is really a place that Bimal can talk more about from the Office of Digital Health. For us, too, as we look at a lot of this work in terms of the implementation, we're trying to really look at those frameworks, whether they be from quality assurance, whether they be from implementation science. So again, we can even think about this integration from research to practice in a systematic scientific way. And this is just an example of one of the frameworks we've been looking at to help us really begin to think about all of the various projects that are ongoing. And with that, I'd like to turn things back to Bimal to kind of take us through the health system and a lot of the work that's being done on the operations side. And the way we're going to do, Lisa and Bimal will have about a 15-20-minute presentation, and we've purposely left time at the end for a lot of questions. So if you have questions, hold on to them, and we will come back.
So yeah, I'm going to hopefully give you a quick overview of how we arrived at the structure that we have within CHOP to support digital health and what our relationship is through the research enterprise. But first, I guess we could have even started with this, but this is sort of just the general statistics about CHOP, and many of you are either from CHOP or know something about us. I did want to point out that we have this very significant educational mission with over 400 trainees across all the six academic departments at CHOP, and that extends into the informatics realm as well. So when you look across both IT and clinical informatics, we do have an abundance of riches in a way. We have a lot of IT folks who are very good at what they do, and we have these 24 physician informaticists. I think that's the true number today. Our 3 EHR medical directors, including Tony Liberti, Eric Shelov, and Eli Laurie, who are all here today. We are very lucky to be partnered with this Department of Biomedical and Health Informatics. And just as a shameless plug for Tony and the fellowship program, we do have an ACGME accredited fellowship in clinical informatics. We recruit 2 fellows annually every year, and we've graduated our third class this year, third class this year of fellows, and they are all already doing amazing things in the field. So as I mentioned very briefly in the kickoff comments, back in 2016, our CEO basically put forth this vision, a call to action around digital health. We did this quick engagement with a consulting company over the summer to try to figure out what we thought the opportunity was. My very first slide where I was trying to define what digital health represented, that was really like 20 out of 500 different topics that came up during this external assessment. And I thought some of the narrative comments were fascinating, things like, we have this, what you got was this sense of that CHOP has this tradition of innovation, and that this was an area where we really needed to sort of stake a claim. And then there were things like, well, we're falling so far behind, and other hospitals are doing this better. There were a lot of conservative voices, people saying things like, we can't do technology just for technology's sake, and I'm really worried that we're going to perturb the system in ways that are going to be bad for us. The bottom left corner is one of my favorites because it isn't, I actually do believe this, that we often have a tendency to chase the bright and shiny objects rather than thoughtfully thinking about where technology might fit in. But across all that, we also recognize that pediatrics perhaps has a very unique opportunity in digital health, that this is probably the first generation where both the parents and the children are all digital natives, and we're also seeing this dramatic shift in what consumers expect of technology. And that's, and the example I give is we as physicians might be sensitive to the idea of seeing a 5-star rating scale on a random website about our own physician performance, but you would never book a restaurant that had a 2-star rating on OpenTable. And so we may not like the idea, but it's going to happen, and we have to figure out how to embrace that change. So what came out of that strategic engagement was these sort of 4 opportunities to help grow the CHOP network, to improve the patient experience, to really, really advance the kinds of research we can do, and to help manage complex kids in their care. And we organize our digital health portfolio loosely to mimic some of that across these 4 pillars. So we have a portfolio of programs called Care Anywhere. These are all the projects we do to support scale and growth, which includes telemedicine and virtual care, Engage and Connect for clinical and operational excellence, really rethinking how we interact with patients and families. What's their first entry point into the CHOP system? What happens once they're in the hospital? How do they make it to their room? How do they register? And things like that, to make it as seamless and frictionless as possible. Research excellence, so this is a lot of what we'll talk about on the panel, but really, how can we support investigators who either want to study the impact of digital health tools or who need a digital health tool to actually do their research? And they're almost 2 sides of the same coin. And then finally, enhance partnerships. What is our opportunity to partner with civic and startup organizations? What can we do to reach out to potential donors and to persuade them that we can go on this really cool digital health journey together? In that first year, we were extraordinarily fortunate to build this team, and I probably am even missing names on this list, but I did want to call out our portfolio leaders, all of whom are here today, and hopefully you'll get to meet at the breaks and at lunch, and our clinical champions and the mHealth team also. And then the fearless leader who reports to me, Gail Stinson-Smith, who I think she's in the back row waving her hand, who has done, again, a tremendous job. And I got to say, one of the, this will come up later as a theme, but this team continually surprises me. Like I'm often like, oh, that doesn't sound like the best idea I've ever heard of, and then they'll completely prove me wrong, which I think is great, that I should just step out of their way and let them do amazing things. So these are sort of the early projects that we focused on. In that first year, Gail and I, and actually all of us, felt like this really strong motivation to just show the organization that we could make these baby steps, that we could actually roll out some technologies and demonstrate that there was potential for really doing more sophisticated stuff in the future. And some of these were great projects for us to tackle because they taught us a lot about change management and organizational behavior and culture within the healthcare institution. So for example, this very first one, the Angel Eye cameras, there are a lot of community hospitals that actually have these web-based cameras in their NICUs so that moms and families can keep in touch with their babies. We have a particularly, it's a different kind of NICU because the kids are much sicker. The majority of them are on ventilators, some of them are on oscillators and ECMO. It's not a community NICU by any means, and it's 100 beds. It's almost 20% of the entire hospital is just these NICU beds. And so installing Angel Eye in the CHOP NICU is a very different endeavor than at a 20-bed community neonatal ICU. And despite that, we've seen this really rapid uptake. We started with about 25 beds, and through partnership with philanthropy, we're able to just complete the 100-bed rollout. And we're seeing thousands of hours of online viewing by these families from not just in this region, but across the country and across the globe. That they're sharing the video links with their families in other countries, which I think is just an amazing testament to this project. I mentioned online scheduling just because it's one of my favorite topics, that it's so much easier to not have to call during business hours and to wait on hold and to negotiate when you can be seen in the CHOP network. For me, I'd much rather do this in the evenings, pull out my smartphone and say, yep, 3 o'clock tomorrow or next week or whatever it is. And we're still making progress on this, right? Today, about 2 to 3% of all of our primary care or all of our care network appointments are made online, but 90-something% of all the online spots we offer, like 98%, actually are filled. So to me, that means that we have a very high demand. It's sort of like if we offer it, it will be filled online. And we have to sort of really start to push how many of these online visits we make available in the first place. This was one of those projects, and I'm going to call out Tracy Haynes, who's here, who actually, I think, actually brought these robots to our attention. This is one of the projects where I looked at it and I was like, that's an expensive toy, that's going to break, some kid's going to knock this off the table. But through persistence, through partnership with the physical therapy and occupational therapy groups, what she found was that these robots can actually augment physical therapy in ways that the human physical therapist has been traditionally unable to do. So for kids who are just really, really traumatized by the inpatient experience, who really don't want to interact with their nurse or their doctor or whoever because they've been in the hospital for so long. And she's got countless examples of kids who would not get out of bed to participate in physical therapy, but who will gladly jump out of bed and play with this robot. And so it's that kind of challenging sort of our status quo. I almost have to follow my own advice of not trying to build a faster horse. Telemedicine, so we are an Epic shop, we have MyChop, and we are dipping our toes, I would say, in these video visits. The biggest challenge has been interstate licensure and also reimbursement parity. And so, we are looking for thoughtful partnerships, either in clinics where the reimbursement doesn't matter, or in populations where we might have a special contract that does cover the cost of telemedicine. So, there is sort of a catch-22 that the divisions and clinicians who might see the value of this don't feel like they have the financial latitude to try telemedicine because it's often an unreimbursed service. And the payers themselves are not always eager to try it out because they don't have the data that it's actually going to save them money or reduce the long-term cost of care. So we're going to continue to work on this, and actually one of the early proof of concepts or really demonstration projects for this is going to be next year. We're going to offer telemedicine as an employee benefit. So if you're a CHOP employee and your child is cared for in the CHOP network, you can get some category of telemedicine visits for your child, including that health benefit. This is another external partnership where we partner with the Norristown School District and are now through this device called the TytoCare device. It's a store and forward telemedicine platform. It's very well engineered. It's FDA approved. We are now allowing the school nurses to basically hop onto this telemedicine suite and interact with a CHOP physician provider in our care network. And this is what that device looks like. I was impressed with this. I saw this at HIMSS a couple of years ago, and just think it's a solidly engineered device. It's got some really nice usability features. If you point it at the patient's mouth, it can identify where the uvula is and will sort of help you center the camera on the patient's tonsils. And it does that exact same sort of guided physical exam for auscultation of the heart and lungs too. And the physician who's in a remote location can actually hear and see exactly what the examiner is seeing. We're working with our dermatology clinic to build a Tele Dermatology platform. I was looking for better screenshots that actually showed rashes and stuff, but the biggest challenge here is to really figure out how to integrate this into our electronic health record, because this really belongs as part of the medical legal record. If we're providing telemedicine as a service for dermatology, record of that encounter should exist in the legal medical record. So that's the part that we're working through right now. We have this idea that all of the comprehensive interactions you have with the health system might benefit from a single platform. So rather than having patients download like 12 different apps for 12 different use cases, perhaps we can bundle this thoughtfully into one application so that whether you're requesting an appointment, whether you want to see where your nearest CHOP clinic is, whether you want to hold your place in line at that urgent care center, automated check-in, medication reminders, and on and on and on, post-op visit questionnaires, whatever the thing is, we think we can put it all into this one application and also make that the gateway to your own personal health record, which in our case is MyChart, which is produced by Epic. And then, because we've mentioned artificial intelligence a few times, we have this implementation of an AI chatbot named Charlie. This is made by a company that was previously called Patiently, or no, it's currently called Patiently. It used to be called Canary.io. This has been really neat. We first did this implementation in the gastroenterology clinic, and what they found was that through these automated messages through Charlie, we would know 24 hours sooner about a patient's intent to either cancel or keep the appointment, which on the operational side is a huge amount of time. It allows us to then, if they say they're going to cancel, go find somebody else on the wait list who might be able to get into clinic sooner. So it's a win-win both for the patients and families, but also for us. And Eric Shelov, who's my Associate Chief Health Informatics Officer, has been interacting with Charlie a little bit around his daughter's care. So he got this text message: "Hi, this is Charlie from CHOP. Just a quick reminder that Lydia's appointment with Dr. Huang is scheduled for Friday. Do you have any questions?" So he replies yes to confirm the appointment, and then Charlie gives Eric a timeline that says, "You should arrive at CareBots at 8:20, check in on the first floor, you have your appointment at 8:40, all that stuff." And then it says, "Is there anything else I can do for you?" Eric says, "Directions." And Charlie says, "I'm sorry, directions to where?" And he says, "CareBots." So then she says, or he, we don't really know Charlie's gender. It's intentionally vague. So here, here's a Google Maps link to the CareBots Pediatric Care Center, gets the direct link to that. And then Eric starts messing with Charlie. "Thanks. Nearby coffee shops?" And Charlie sees through Eric's wily ways and says, "Google should also pull up locations of any coffee shops in that area." But this is a pretty superficial example of what Charlie can do, but we can also put in disease-specific or clinic-specific FAQs, and I think we have an exploration project that Lisa will show where investigators are going to start to use this for post-op or post-visit follow-up questionnaires. So there's a lot you can do with Charlie, and imagine all this in some point in the past was all human effort, right? Like the countless calls about, well, does my child need to be NPO before this study, and what time do we have to show up, and where's the nearest parking spot, and all that stuff. We are also investigating the use of MyChop Bedside. So this is the inpatient portal. So the idea would be sort of an inpatient, interactive patient experience. So if you're hospitalized at CHOP, you can follow along in your child's care and see your active problem list, your recent lab results, the members of your care team along with their bios and what their special interests are. And hi, I'm Bimal Desai. I'm your attending physician, and I like long walks on the beach, and all the stuff they would probably want to know about me, or maybe not know. And then their medication list, so they can actually learn about these medications, who prescribed it, what dose, what does this thing actually treat, and why am I on it. Recent vitals and trends in their lab results. And you can imagine a lot of this was a clinical negotiation. We had to talk to the leaders of the inpatient units and persuade them that it was safe to release these lab results within a certain number of hours. There's this sense of like we're still the gatekeepers and we can't show these lab results to families unless the physician has seen it first and had a chance to vet it. And so there's a distinct push-pull, I think, that we have with clinical communities about what these technologies represent, what that transparency specifically represents. So what have we accomplished? Well, so I've tried to highlight 4 or 5 of these big projects. And I think, again, the thing that I'm probably the most proud of is that in 2 years, we basically took this, the output of that consulting engagement, and we're actually able to develop a really robust team around it. Gail and I both have long-standing partnerships within IAS, but also with the clinical communities, and I think that's really helped us to sort of figure out how we're going to talk to individual divisions and say, hey, you know what, you've mentioned this problem many times before about X facet of how you care for patients. Would you consider this kind of technology, or is there an opportunity for us to think about a different way to solve that? We want to keep doing this, sort of cut, copy, and paste over and over and over again. All the small problems, the pebbles in people's shoes as they care for patients, and really try to find the opportunities to thoughtfully introduce these technologies. So our emerging themes for FY19 on the heels of our very recent enterprise-wide strategy retreat 2 weeks ago is we're going to double down on this interactive patient experience, this IPX project, this idea that we can really, really change what the inpatient experience feels like for families. We're going to continue to expand this mobile app platform and try to put in more and more technologies into it, whether it's research questionnaires or wayfinding or whatever the thing is, to make that sort of an indispensable tool for families as they interact with the health system. We really, really want to pursue telecare and telecoordination for complex chronically ill children, and are looking for these partnerships with either specific populations or people that oversee population health initiatives and things like that. Our chair of the Department for Behavioral Health, Tammy Benton, is very bullish on telemedicine as a strategy. In this region, we have an extraordinary shortage of behavioral health services for kids, and it has myriad consequences both for those children but also for our health system. And Joe Zork, who's in the audience, can talk to you about what it's done for the emergency department, that we see lots of kids in crisis and we don't have the mechanisms to really triage them or to intervene sooner. But Tammy feels like, and I agree, that telemedicine really allowing our therapists to talk to kids, whether it's at home or in the school setting or in their primary care doctor's office without requiring a special referral, it would be an enormous, enormous thing to do to serve this community. And then last but not least, and Lisa will talk about this more, is I think there's a lot we can do to help the research community too. Whether it's specific tools to help them do their research, or whether it's partnering them to help us evaluate the impact of these tools that we're rolling out on the operations side. Like, there's a lot that we can do in both directions. So thank you for that, and Lisa Schwartz is next.
You did test your video and it does work.
Welcome. So I'm a behavioral scientist in oncology. I'm a psychologist by training. I actually will have to leave soon because today's my clinic day. But my research is focused mostly on adolescent and young adult survivors of childhood cancer. And so you will see that, see why sort of my interest in digital health evolved from there. In the interest of time, I'm going to skip forward that. So why mHealth for pediatrics? Well, in particular, in my patient population, the long-term survivors are coming from very far away. And I think this is true of many specialties in pediatric care. So the accessibility issue, Bimal mentioned telemedicine, so for many of these patients are coming hundreds of miles away. And If they're off treatment, then they're not having frequent visits. So again, this is true of a lot of our population, not just for childhood cancer survivors. So the digital health provides a tool to reach those patients that aren't going to be seen in community settings. Bimal also mentioned that both the children, adolescents, and the parents are digital natives. So we see that research shows that in this age group of both our young adult parent population and the PEDS patients, they're using their smartphones all the time and using it to access information. We also know that for there's so much heterogeneity in these pediatric chronic health conditions as well as their development. So an 8-year-old looks very different from a 12-year-old, looks very different from an 18-year-old, which may not be the case if you're thinking of an adult patient population in their 40s or 50s. So the idea that we need to provide very tailored interventions and information based on this high variability and heterogeneity of development and chronic health conditions is important. And also, research shows huge issues in health literacy and health disparities among pediatric populations, especially those coming to CHOP. So in particular, if we think about adolescents and young adults and just focus on that population, it goes without saying, it's been mentioned, they're using their smartphones for everything, and even those from low SES families typically have a smartphone. So in our CHOP population, my colleagues and I, we always assess this at the beginning of a study, and typically over 90% have a smartphone when you're thinking about adolescent young adult patients. We also know that they prefer text messaging as a mode of communication over paper and pencil or email or in-person discussions. So I actually find that quite challenging. I do a lot of text messaging research, but you can't put everything down in a text message, but they don't check their email or answer their phone. So challenge to tackle. They're also incredibly transient. So they may or may not be living at home. They're switching apartments. They're moving from high school to college. So the idea of trying to track them via email or a regular phone number or a home address is very difficult. If we know that they have access to an app from us, or we have a accurate phone number to be able to text message them, that's a way better way to provide an intervention when they're so transient. And then we also know that adolescents are really not great at adherence, and health promotion is also a major issue. Physical activity, diet, and these are health behaviors that we know are really amenable to digital interventions. Here are some statistics to support what I was just saying. It's probably a little dated at this point, even a couple years old. But to echo what's been previously said, teenagers more than any group are using the internet a lot to look up health information, probably more so than their parents. And they're even looking up at the internet to look up both positive health behaviors and negative health behaviors. So the last point on this slide is, something to also consider is they're maybe looking up drinking games, eating disorders, committing suicide. So something to consider. It's a special consideration with pediatric adolescent populations. So in my research, I've done some app development, text messaging, dabbling into biosensors, which I'll talk about. I find that there's some particular challenges, and just like there's so much heterogeneity in the pediatric adolescent population, there are also so much variability in their preferences, and their threshold is really high for keeping their intention. So app designs that maintain adolescent attention and engagement are complex, costly, and not often considered by app developers. So I've worked with a couple off-the-shelf apps that we've modified, and there's this real tension. And I don't mean that to throw any of the design or technologist people under the bus, but it's a real tension to understand that what may work for an adult population may not work for a 15-year-old or an 18-year-old, or, which kind of blows their mind, sometimes it might work for a 20-year-old, but not a 16-year-old. So there's this huge variability and preferences that have to be considered. So I'll show you an app that we modified from an existing disease management app. And some of the feedback is this seems like a beta version. We want more colors and more tailoring. They don't like, so in the app, you see the messages within the app. The text messages don't go directly to their text messaging feed with the rest of their messages. They don't like that. It seems like one extra step to be able to look at the app. And I don't need an app for that. My phone already does that, you know, in the example of a step counter. So, you know, and I think this is all really worthwhile and viable feedback. This slide I borrowed from a colleague at Cincinnati Children's, and you don't need to look at the details, but really what this is showing is that you can get down to the weeds in terms of aspects of a digital health intervention and the actual preferences by age. So across the top, there's it lists hunting for things to click, tab browsing, scrolling, search, level of patience, animation and sound effects, and then you see on the left the different age groups. And basically what this is showing you is there's so much variability, as I've been saying, in terms of what their preferences are across different age groups, when you even just get down to those small components. Other considerations in pediatrics, you know, there's always an issue too of if you're providing something for an adolescent or young adult or even potentially a school-age child, is there a parent component to that? Or vice versa, if you're designing digital health intervention for a parent, is there some school-age or AYA version of that? So to consider having companion versions of that. Another important consideration is this tension of we're really not trying to encourage our children to be on their phones all the time. And similarly with parents, we don't necessarily want to encourage them to be on their phone all the time when, you know, it may be contrary to important attentive parenting. So how do we balance that? We're going to give you this information. We want you to engage in this intervention via, looking at text messages, answering questions on your phone, using an app, versus trying to encourage just a moderate amount of that. Another real issue too, of course, is when children are in school, we can't expect them to be engaging with a phone then. And even so, I've had young adults in my interventions who are just, have jobs and they're trying to, establish some sort of credibility with new employers if, they're young adults. And so the idea of doing anything on a phone during the workday is a challenge also. There's also, the idea of how do you incentivize gamification, maintain engagement is kind of a different ball of wax in this population. A great example that I often hear colleagues talk about is for those of you who know the Way to Health platform at Penn, which is, and facilitates behavioral economic interventions through payment of positive health behaviors, like opening your pill bottle and taking your medicine for the day. They deliver money through money wired to their checking account. And so that may not work for a 15-year-old who doesn't have a checking account, or even if they do, it may not work in the sense that they may not recognize that immediate gratification if it's some virtual transfer of money that is not tangible to them. So Way to Health has, I have had colleagues working with Way to Health on different incentive plans. So in our preliminary designs, when we're thinking of these interventions, Certainly, there's things to consider like language, reading level, cultural specific, idioms, really getting stakeholder feedback and doing usability testing. And this is basic components of user-centered design, and I'm by no means an expert in user-centered design, but I think it goes back to what Linda was saying, is that to do this right, and especially if you're thinking about doing this from a research standpoint of a randomized control trial, you want to get it really right the first time, and it takes a lot of preparation. And with that, partnering with not just technologists, but people with expertise in design is really important. I also borrowed this slide from a colleague. This is my colleague Nadia Dashians, and this are some screenshots of her app for adolescents with HIV. But this is just, again, an example of the details to think about in terms of testing it with her adolescent stakeholder population, is thinking about icons, colors, motion, photography, and these are just a few of the examples of components to get feedback on from stakeholders. So I'll go really quickly with a few examples of my research. I have one ongoing randomized control trial called AYA STEPS. And this is a randomized control trial of AYA, adolescent young adult survivors. And we're looking at the benefit of giving survivors an app along with a survivorship care plan, to see if the app helps enhance uptake of that care plan versus the care plan alone. So this is actually a blending of two different independent programs of research. The digital survivorship care plan started at Penn. You could Google this. It's Onco Life. It's freely available to anyone. The pediatric version is Smart Alec. So my colleagues, my physician oncology colleagues, worked on the development of this platform, adapted it for pediatric diagnoses, to be able to input through drop-down menus information about cancer history, treatment history, demographics, to develop a survivorship care plan with information about potential risks, need for surveillance, health behaviors, etc. And then I had started with a text messaging intervention for adolescent young adult patients who recently completed treatment. So we merged these in response to actually an RFA from CDC looking for survivorship care plan self-management interventions. And so in this intervention, everybody gets the care plan, and like I said, then they're randomized to get the app or not. Here are some screenshots of the app. This was adapted from an existing disease management app from a company called Life Science Technologies. So the care plan's housed on the app. They get tailored text messages through the app, tailored to things like their risk for late effects, the treatment history they had, whether they're an adolescent or young adult, whether they're at work, whether they're working or in school, a variety of different tailoring algorithms. I'm going to skip forward and show you that you have joined our study. My name is Dr. Lisa Schwartz, and I'm a psychologist in oncology at the Children's Hospital of Philadelphia, and I'm also one of the study investigators.
My name is Dr. Dava Zalda. I'm an oncologist here in survivorship at the Children's Hospital of Philadelphia and also at the University of Pennsylvania. I'm also one of the investigators of the study. This video will give you a quick tour of how to use the AYA STEPS app.
The app has a lot of great features, especially the text messaging. We'll send you 1 to 2 texts each day. New text messages will appear on the front screen of the dashboard. To respond to a text, click the conversation box below the new message. Select the text. Then type in your answer as you would with a regular text message. You may also read old text messages in this section. Remember, you earn points by responding to text messages. Cash in those points later on to purchase a gift card of your choice. You can also send a text message to the study team, and someone will get back to you within 24 hours.
Check out this other important feature. The app has your Survivorship Care Plan, or SCP, right here. Go to the bookshelf below the text messaging section to find this. You can see your full care plan, or FCP, or look at specific chapters of your plan, such as follow-up care. You simply click on the section that you'd like to read. You can download your survivorship care plan directly to your phone so you can find it easily after the study ends. That way you can share your care plan with anyone who needs to know about this information, like any new doctors. For instructions on how to save your survivorship care plan to your phone, go to the second bookshelf at the end of the dashboard. Here are some other cool features that the app has to help you stay on track with your health. A list of your medications, a list of your upcoming appointments, a step counter that syncs to your phone or your Fitbit, and a calorie counter. If you need to reach the study coordinator or the phone nurse, you'll find those phone numbers at the bottom of the app.
One last thing, be on the lookout every week for 1 or 2 surveys from us. You'll know a new survey is waiting for you to fill out when you see a flashing notification on your dashboard screen. Click on the survey and select your answers on the 1 to 10 scale. Based on your survey responses, you can track your weekly progress over time with this graph.
Thank you so much for watching this video and for participating in our study. We hope you enjoy the app.
Thanks. Bye-bye.
Also doing a study testing the use of actigraph and EMA, ecological momentary assessment, with adolescent young adult survivors. Actually, our keynote speaker, Stephen, mentioned a study with childhood cancer survivors monitoring heart rates or cardiac functioning, and we know that there's huge cardiac risk in childhood cancer survivors, and they're also incredibly sedentary. So we're just piloting this in our patient population, actually with a platform developed with colleagues at Penn to use actigraphs and also have track EMA. So they're going to get questions about mood, location, fatigue, et cetera, to see how their context is impacting the information we're getting from the actigraph. And then Bimal mentioned Patiently. So I'll finish off with just an example of how we are using Patiently for a research study. And interestingly enough, this is a study testing acupuncture in adolescent and young adults who have cancer to treat pain. It's a non-randomized trial, so we're going to track pain no matter what. And they are going to be given the option of acupuncture, which is a relatively new service at CHOP. So I had sent out a broad message in the fall saying, I need some platform to just send text messages to ask patients what their pain, to do daily pain ratings. And I landed with Patiently. So it's a nice example of how we're integrating sort of clinical operations rollout, also testing it in a research study. So basically, we're going to use Patiently, this Charlie CareBot, to send messages daily to do a brief pain diary, and then if they are in the acupuncture group, if they want acupuncture, then we will use Patiently to send them appointment reminders about their acupuncture, and then also once if Epic registers that they attended that appointment, then they will get subsequent questions asking about adverse events from that acupuncture, which we honestly don't expect adverse events, but necessary part of this trial. And so we'll also be able to send links to the larger research questionnaires through Charlie the bot, and he or she will send messages to remind the participants to complete those study questionnaires. I'll stop there. Thank you.